Good afternoon, everyone. We're going to bring our slide deck up. I'm Dr. Jean Connors, a hematologist at Brigham and Women's Hospital in Boston, Massachusetts. I'm on the steering committee for the AC Forum and delighted that you've joined us here this afternoon. With me to start off is my colleague, Dr. Katelyn Sylvester, who with me is in charge of the Hemostatic Antithrombotic Stewardship Program at Brigham and Women's Hospital. And today's program includes the broad title of Outpatient Anticoagulation Stewardship, focusing on DOAC oversight models in anticoagulation management services. Today we have with us on the next slide our presenters, Dr. Arthur Allen, PharmD for the VA Salt Lake Health Center. We have Dr. Andrew Geller, who's Chief Medical Officer and the Medication Safety Program at the U.S. Centers for Disease Control. Katelyn Sylvester, who works at Brigham and Women's Hospital with me in all things coag related, and our moderators are myself and Andrea Van Beek, who's an RN and anticoagulation clinical nurse practitioner at the Visalia Medical Clinic in Adventist Health Physicians Network. So we're going to turn this over now to Katelyn Sylvester, who will take us through the first presentation of our webinar.
Sorry about that. Always forget to unmute. Thank you, Jean, for the introduction and for kicking us off. So today we're going to talk about outpatient anticoagulation stewardship, specifically focusing on how we incorporate DOACs. So since DOACs became available about a decade ago, they've continued to shift anticoagulation management practices. DOACs have replaced warfarin for the primary anticoagulant of choice for atrial fibrillation and venous thromboembolism, both in guidelines and in clinical practice, at least in the United States and really worldwide. DOACs have also interestingly captured a large portion of the patient population that was previously not anticoagulated for atrial fibrillation. You can see on the right that from 2016 to 2020, not only did DOAC prescriptions increase by 83%, but overall oral anticoagulant prescriptions increased by almost 20%, which is huge. Part of this reason is DOACs are quote unquote easier to manage and improve patients' quality of life, which is true, certainly not without drawbacks, and it's not a easy magical bullet, but compared with warfarin, there's no routine anticoagulation monitoring, so we don't need patients trying to figure out rides to get to the lab, to monitor their INR, or to have to prick their own finger multiple times a month. They offer easier fixed doses. There are definitely some dose adjustments depending on the disease state and the clinical characteristics, but overall fixed doses, much fewer drug-drug interactions and food-drug interactions, and less major bleeding. Oops. The reason why I say it's not a magic bullet is that we still do struggle with bleeding. So although the rates of major bleeding are around 1 to 3%, when you multiply bleeding rates times the huge amount of population in the United States that are using oral anticoagulants, we still have a massive problem impacting our healthcare system and our patients' quality of lives. Dr. Andrew Geller from the Centers for Disease Control and Prevention and his colleagues very recently published on this data, looking at the impact on our national healthcare system for bleeding-related adverse events related to oral anticoagulants. This was a really interesting study that looked at a national surveillance sample of 60 hospitals and looked at ED rates for oral anticoagulation-related bleeding over 5 years. And then they used that estimate to multiply out the overall exposure to patients who had received prescriptions for oral anticoagulants and filled them in retail pharmacies across the United States. And from this data, they estimated that there were over 1.2 million ED visits for oral anticoagulation-related bleeding during this 5-year period, with over about 250,000 ED visits annually, which are huge numbers. And about 87% of all the adverse drug events related to oral anticoagulants were actually for bleeding. And I think, we know that warfarin and the DOACs are a huge reason for ED admissions for patients on oral anticoagulants, but I think I at least wasn't as I didn't think that DOACs really contributed as much as they are. And you can see from this data that about half of all the visits were actually due to a DOAC, not just warfarin. And you can see that there were 5.9 ED visits for 100 patients on DOACs compared with 13 for warfarin. So numerically, the number of visits per DOAC patients is smaller, but the number of patients on DOACs is just huge at this point. And so we still have quite a bit of bleeding that is forcing patients into the emergency room, and about half of those patients are actually admitted to the hospital. So this is just huge. 1 ED visit for bleeding per 27 patients prescribed a DOAC in 2020 from the estimates from this data. I think we're starting to hear over and over again a similar call to action from many different sources, both nationally and globally. And just to read a few quotes that came out from data this year, further bleeding prevention efforts are warranted alongside efforts to expand appropriate use. And these are all notably talking about DOAC management. Efforts to improve appropriate prescribing and monitoring of OACs remains important in the era of DOACs. And then this last one came out from colleagues in Italy. It's anticipated that both patients and health systems would benefit from such comprehensive organization. And this was referring to anticoagulation management services looking at DOACs similar to how they look at warfarin. Back in 2016, we were hearing similar things with the ASH guidelines, quoting that organized anticoagulation management services for VTE prevention, even for patients on the DOACs. And Barnes et al. Also published a manuscript around 2016 calling for an urgent need for centralized management of patients on DOACs. So what are some of the potential roles for a DOAC clinic for an anticoagulation management service managing DOACs? There are a couple here. I'm sure there's many more, but I'm just going to focus here. One is we need to be able to evaluate the need for concomitant antiplatelet use. In the Geller et al. Publication, about a third of all patients who were bleeding were actually on an antiplatelet therapy as well as their anticoagulant, and 7% were on dual antiplatelet therapy or an antiplatelet other than aspirin. So this is certainly some place that we can modify the bleeding risk for patients, is discontinuing antiplatelet therapy if it's no longer needed or there's not a strong indication. Another area is ensuring the correct dosing at the time of initiation and with any changes in clinical status. We know that there's been lots of papers published over the last decade saying that patients often aren't started at the correct dose of anticoagulation, and that we also may not catch that we need to down titrate an anticoagulant once the patient has a change in their clinical characteristics. Another important piece is planning for procedures and surgery. Two main things might happen here is one, the surgeons or proceduralists are unaware that a patient's on an anticoagulant and they're exposed to an increased risk of bleeding, or they become aware right before the surgery and the surgery has to be either canceled or postponed. So this is another great place for a centralized anticoagulation management service. We can also assess for potential drug-drug interactions with changes to the medication lists, which happen throughout all of the phases of care. Provide ongoing education and support for patients, generally speaking, about their disease state and their anticoagulation management, but also specifically about medication adherence. This is another area that has been cited in the literature, that DOAC medication adherence is as bad or worse than warfarin adherence, and that does impact patient outcomes. And we can also help triage minor or patient-relevant bleeding events, or also help patients determine when they need to present to the emergency room. So what does a DOAC management model look like? As you can see from here, it really can range from a whole spectrum. One example is mimicking the warfarin management model, where you have an individual patient-focused visit with scheduled check-in points and then additional as-needed interventions. On the other end of the spectrum, you have a population health model where you might have oversight of a very large population of patients on DOACs, and you don't intervene until certain rules are triggered. You may have a hybrid approach where you have a small panel of patients that you deem are very high risk that require close management, and then have oversight of a larger, lower risk population, and really anything in between. And the best model really will depend on your population, what IT and human resources you have available to you, and probably will continuously evolve over the time of your DOAC clinic. So we wanted to start out by giving an example of the Brigham and Women's AMS clinic, which is where I work. And we very much mimic that warfarin management model, where we have individual pharmacists managing individual patients on the direct oral anticoagulants. So for our leadership, we're lucky to have 2 co-medical directors, a cardiologist and a hematologist. This is a pharmacy-run service, so we report into the executive director of pharmacy and ambulatory director of pharmacy. I'm the pharmacy manager. We have 10 full-time pharmacists and a part-time pharmacist, 1 operations coordinator, and very recently, 3 full-time and 1 part-time patient navigators, which replaced our previous pharmacy intern model. We try to practice at the highest part of our license. We're recognized as an Anticoagulation Center of Excellence by the AAC Forum. We do have 15 credentialed mid-level practitioners practicing under collaborative practice agreements, which includes our per diem pharmacists. 6 pharmacists are certified anticoagulation providers with the CACP designation, and 6 pharmacists are board certified in either BCPS, BCACP, or BCGP. We have a virtual clinic model for both warfarin and the DOACs, where our primary method of communication is telephonic, although we do also communicate via patient portal for those patients where that's preferred. Under our collaborative practice agreements, we really have full scope of anticoagulation management services. We will help with the initiation and selection of the right anticoagulant for the patient based on their clinical characteristics and insurance formulary. We'll provide initial dosing and dose adjustments. We will coordinate the peri-procedural management with the proceduralist, cardiologist, oncologist, and any other stakeholders involved in the patient's care. We help with transition between anticoagulants. We provide education and counseling on adherence. We also have a 24/7 emergency support pager where we triage adverse events. We do medication refills as well as prior auths and any other medication procurement that might be needed. You can see here that we have about 3,400 patients that we're actively managing. We still have more warfarin patients than DOAC patients, but every month this curve kind of changes itself a little bit as we get a few less warfarin patients and a few more DOAC patients, although I definitely think the decline of warfarin is much slower than we had anticipated a decade ago. Here below, you'll see our average patient pharmacist panel is about 300, which I know to everybody who loves these panel numbers, it is a little bit deceptive because our pharmacists do have oversight for other patients with atrial fibrillation, titrating their rate and rhythm control agents. But in general, we have about 170 warfarin patients and 130 DOAC patients per pharmacist. I believe that we oversee the anticoagulation for probably 100% of the warfarin patients associated with the hospital and the physicians organization, but probably only around 10 to 15% of the patients on DOACs. And this is basically because that's what our resources are available for at this moment. We get our enrollment of DOAC patients based on referrals. So we can get direct referrals from the providers. We provide warm outreach for patients discharged from the ED or inpatient setting with a new DOAC start, as we had identified early on that this was an area of improvement we needed in our organization. We also provide warm outreach to targeted PCP groups where we'll manage their DOAC patients for them. And certainly we have our own BWH AMS patients who we transition from warfarin to a DOAC. We originally launched our DOAC clinic in the summer of 2017, and you can see here our original management plan. At the time, we had discussed with many other AMSs around the country who were starting to kick off DOAC clinics, and what we had been advised is to have a really high-touch upfront model so the patients started to build a relationship with the clinic and the pharmacist, and then sort of back off our management from there so that we weren't over-managing the DOAC patients. So the way we do it is that we enroll them into our clinic. We have a really long intake visit where we do all of our patient education. We'll order labs. We'll do any counseling that they need. We'll talk about adherence. We'll go through their med list with them and set up any new prescriptions. Then we follow up at 1 week to make sure that patients were able to pick up their prescription, didn't have any signs and symptoms of bleeding, didn't have any other concerns, and provide any re-education that might be needed. For VTE, we follow up with any patient that needs a transition, either from low molecular weight heparin to a DOAC, or who need a dose de-escalation after their initial lead-in period. Then we follow up at 3 months and 6 months with standardized questionnaires. And then at 6 months, we stratified the patients based on risk. When we originally decided to stratify the patients, we really stratified based on risk of a bleed or an event. And so we were looking at high-risk patients as those patients who were over 75 years of age, who had poor creatinine clearance or had known poor adherence. And so that's, you can see here on the right is what our each visit, what we looked at. So compliance, thromboembolism symptoms, bleeding symptoms, any other side effects the patient may be experiencing, and any new co-medications. And then you can see, we'll go into further on this, but how often we assess labs. So we published our experience in 2017, and then we looked back at 4 years in 2021 to see how our DOAC clinic was going, and also updated some of pieces of our management plan. So we realized that we were spending a lot of time doing chart reviews with the current risk stratification. So we had high-risk patients, but they were already dosed appropriately at the lowest dose of the anticoagulation, depending on their patient characteristics. So for example, they may have already been on apixaban 2.5 milligrams BID. So despite the fact, that they may have fluctuating renal function, there wasn't a lot for us to do as a pharmacist. And so instead, in 2022, we kind of flipped our stratification model and moved patients either into this active surveillance bucket or maintenance bucket, with active surveillance patients requiring a chart review every 3 months, and maintenance patients after the first 6 months only requiring a yearly visit. So you can see here that our actual management plan didn't change, but what did change is that stratification. So here, instead of stratifying basically by age and by renal function, we actually looked at each individual agent specifically and looked at when they would potentially need a dose adjustment, and using those cutoffs to determine if a patient required active surveillance or maintenance. So for example, a patient on apixaban with non-valvular AFib, if they weren't already dose reduced, but they had one of the 3 criteria, then they would stay in active surveillance, so that every 3 months we could check on the patient and make sure that they hadn't then met 2 criteria and require a dose reduction. For VTE, those patients would be in maintenance mode, assuming they needed longer than 3 months of VTE treatment. And same with extended duration VTE. Once we've assessed the dose to determine if they needed dose de-escalation, they would stay in the maintenance phase. For rivaroxaban, it depended on the indication, the current dose they were on, as well as the renal function. So for example, non-valvular atrial fibrillation, if they were on Riva 20 milligrams once daily and their creatinine clearance was less than or equal to 60 or fluctuating, then we would check in on them every 3 months to make sure that their creatinine clearance hadn't dropped below 50, requiring a dose adjustment. And you can see that this follows all the way through the indications as well as the different DOACs. So our active management mode is what we do for our first 6 months, which is where we assess adherence, educational needs, signs and symptoms of bleeding and thromboembolism, side effects, co-medications. And we're always here to coordinate upcoming procedures and surgery, and to assess the ongoing need for anticoagulation and appropriate dosing. But after the initial 6 months, we break them up into either active surveillance or maintenance, which I already talked about a little bit. But for active surveillance, we are going to do a chart review every 3 months to assess the need for a dose change and ordering any labs. We're also available to provide peri-op management plans and have our patient support and on-call emergency pager for questions and triage. In maintenance mode, we are only offering the patients at this point perioperative management plans, as well as support with education and on-call emergency pager. And then yearly, all patients will undergo a yearly annual renewal. And this is regardless of what management plan they're part of. During that period, the pharmacist will go through the patient's chart. They will make sure that they still have a referring MD that's actively managing them at the Brigham. They will assess their ongoing need for anticoagulation, as well as any changes to their risk of bleeding and thrombosis, assess the need for prescription renewals and prior auths, as well as lab order renewals. They'll make sure that the patients had yearly labs either ordered or obtained, including liver function test, creatinine, and a CBC, assess any new medication added, and assess adherence and ongoing need for education. And at this point, they will make a call to the patient to make sure they're doing okay, check in on adherence, any other questions they have. A patient can move throughout these categories at any time based on changes in their clinical status. So if they were in maintenance category, but for some reason have had a bump in their creatinine, they might move back to the active surveillance category. Or as they age, they again may also move closer to the active surveillance category. For our lab monitoring, baseline, we get creatinine, CBC, LFTs. We also get age and weight. And then on an ongoing basis, for those patients in active surveillance or whose renal function might be fluctuating, we're looking at Q3 month creatinine checks. But for everybody else, we're ordering a creatinine every 12 months, unless for some reason they may need to use Lovenox or something, and then we get a more up-to-date creatinine. CBC, we get at least yearly, liver function yearly, and age and weight we assess at each visit. And a patient may need more frequent follow-up or labs if they have experienced adverse bleeding events. So the pharmacist will follow them more closely after that event. We looked back at our data over the 4 years from June 2017 to June 2021. We had about 1,600 referrals and 3,000 follow-up visits. You can see here our breakdown of patients that we manage, with the majority being apixaban followed by rivaroxaban. And during these visits, we found that about 10% needed help with acquiring the medication upon original referral. Either their insurance didn't cover it, or they had a copay card when they left the ED, and then they weren't sure what to do from there. 4% of patients were identified as not taking the DOAC as prescribed. Another 5% required a DOAC adjustment, and 20% of patients required a procedure plan managed. I then took a quick look at our fiscal year 2022 data, and we had done just in that year alone over 500 procedure plans. So certainly this volume has picked up since 2017. So some of the strengths of this model are that we already use DOAC as our software, and we were able with minimal IT support to implement this DOAC clinic in a stepwise approach. We all have to start somewhere, and we didn't have the ability to do a large Epic build. And so this was an easy way for us to continue to monitor the DOAC patients that we had. You can continue to provide care to the patients who transition to a DOAC, and this was really important to a lot of our patients who had long-term relationships with the pharmacist on warfarin. They didn't want to be transitioned to a DOAC if they couldn't still have contact with the pharmacist. And I think a lot of our physicians felt the same way. We had a slow uptake moving from warfarin to DOACs, and I think part of that was they knew the AMS would take care of all the warfarin patients. Another strength is that patients have a pharmacist on demand available to them 24/7 for emergencies, questions, patient educations, and then also a pharmacist available to help coordinate procedure plans, somebody who is really focused on the anticoagulation piece of their care. And all patients get an ongoing yearly assessment for their need for anticoagulation. We all know there's a huge problem with starting really any medication and then forgetting it, and it stays with the patient forever. And so having a yearly assessment of the need for anticoagulation, as well as the bleeding and thrombosis risk, and being able to modify any risk factors that are modifiable, is super advantageous to our patients. Some of the limitations of the model is it's very time intensive to do these chart reviews. It takes a lot of pharmacists to do the chart reviews and patient calls in order to identify the clinical interventions. We may miss potential interventions based on the timing between encounters. And so if you're only seeing a patient every 3, 6, or 12 months, and something happens right after that scheduled encounter, then you may miss a potential dose reduction needed. And patients and providers often forget to alert AMS when they've scheduled procedures, and so this can be a big problem. So my next steps, which we're lucky to hear from Arthur after this, is to move towards a population health model that I've been trying to work on for about 3 years, but it's hard to build the IT infrastructure and really have a rules-based alerting system. I envision that we'd have initial enrollment would still be very hands-on, providing education, ordering labs and prescriptions, medication selection and dosing. And then after that, the majority of patients would be transitioned to active surveillance, where the AMS providers are alerted to review when certain rules are triggered. And we would still include a yearly renewal for each patient to make sure that they do still have this ongoing need for anticoagulation, and we're able to order any prior auths, prescriptions and labs that they may need. So now I am going to transition this over to Arthur to talk about the population health model.
And while Arthur's pulling up his slides, I want to thank you, Katelyn, for an excellent presentation. And I will want to reiterate that if you want to ask questions, please put them in the chat, and we will have a panel discussion following Arthur Allen's presentation on population health models. Thanks.
All right. Thank you so much. Try to get this thing into full screen mode. Here we go. All right, so thank you, Katelyn, for a great presentation. I want to talk a bit about population health model and its application to DOAC oversight. But first, I think we need to describe what the heck is population health. And when operationalized, I like to think of it as working smarter, not harder. So if we look at a model of traditional care where you have one provider kind of with one patient at a time, going through the motions, they meet with the patients, perhaps on some scheduled basis, they look at labs, they order labs, they ask a bunch of questions, they review medication, they evaluate, and essentially what they're trying to do is find something where there's not a negative answer like everything's cool. They're trying to find something that they need to intervene on. And here, what that's demonstrated by is this person in red here. So they've gone through all of the motions with all of these patients, and they found that actually everything's hunky-dory, everything's groovy, but it's taken all of that time to get to the patient that actually needs something. Population health, when operationalized, says, what if I were to take that same provider and build computer logic that does the screening that that provider would be doing on an individual basis? What if it can, for the sake of DOAC management, what if it can look at indication and look at dose for indication and look at patient-specific factors and look at potential changes in laboratories and screen for drug interaction and so on? What if it could do that? And every time there's nothing wrong, it simply bypasses the patient and sends the provider only to the patient that needs something. This is what we mean when we're referring to operationalizing population health. So then what is a population management tool? Well, taking that same approach, you can build a tool that obtains data from the electronic medical record and with the use of computer logic, evaluate current patient data against clinical standards, and provide then a dynamic interface for clinician monitoring of multiple patients, an entire population of patients. That provider is then informed regarding cases where it may need intervention, bypassing everything else, as we mentioned on the previous slide, and also allowing for tracking and trending and of quality issues for that entire population of patients. Now, you may be familiar with other, digital tool models. So clinical decision support is pretty common in the modern electronic health record. So you go to order a medication, and it pauses you and says, wait a minute, the patient's renal function, that's the wrong dose, you should use this dose instead. Or here's an order set that walks you down the pathway of how to treat something. Those are great, and they display guidance at the time of order entry. They impact clinical decision-making for a single patient, but they're not responsive to changes in the clinical status. So if you, for example, the order set leads you to dose this way for the patient's renal function, and then there's a change in the patient's renal function tomorrow or the next day, it doesn't have a means to capture that. You may, on the other end of the spectrum, you may also be familiar with quality management dashboards, high-level kind of system-level tools. If you're familiar with SAIL reports or these kind of things, or where it can retrospectively evaluate performance over time, say surgical infections or the treatment of community-acquired pneumonia, that kind of thing. Now, it can indirectly impact clinical decision-making for the future care of patients. So, for example, if your report says, hey, we've had a run of cutting off the wrong limb on patients, that might influence change in the hospital to no longer cut off the wrong limb of a patient. But it's not responsive to changes in an individual clinical patient status. Population health management rides in the middle of this, and it provides proactive surveillance for problems in real time throughout the course of care. It guides interventions on multiple patients, and it's responsive to changes in the individual patient clinical status. So with all of that in mind, what would it look like with regard to DOAC management? What would it look like if you could build a tool that daily reviewed every patient prescribed to DOAC, spending time only on those that may need something? So what if every 24 hours, every patient prescribed to DOAC was reviewed for dosing issues related to their indication and their patient-specific factors, notable labs, drug interactions? What if you were flagged when it's a female of childbearing potential, or if there's ICD coding for valves, bariatric surgery, or antiphospholipid syndrome, or simply because you're not really following these patients terribly closely, you don't want them to run out of med, and it tells you when they need to have a med removal. Or perhaps it tells you when they're not putting the pill in their mouth and swallowing it, and it suspects that there's non-adherence. This is what has been built in the VA system, and this is a mock-up that was published in the Journal of American Heart Association back in 2021, where it shows kind of the dashboard. This is what the actual tool looks like. This home screen provides an overview of the number of patients currently in play for each area of concern. So if you look on the left where it says total number of patients, at that site, that's indicating that that number of patients are prescribed DOACs and having this logic in the background applied every 24 hours. And the columns to the right are the issues where it's picking up something that may be a potential clinical concern, where the logic is broken, if you will. So the dose seems to be wrong for the indication and patient-specific factors, or are concerning labs that have come up, or yesterday someone tried to prescribe rifampin for this patient, and today I'm being told about it instead of 6 months later at some scheduled follow-up visit. So this allows the healthcare team to prioritize really and filter flags based on the reason for clinical concern. And you see that each of those numbers are hyperlinks. So by clicking the hyperlink, it brings you to a group of the patients with that common problem and allows you to then individually evaluate the patients clinically. You can also drill down into individual patient data, which looks something like this. You can see in this simple view, I'm handed information of the patient, their identifier, their age, their weight, their BMI, their diagnosis based on their ICD-9 code, not because I told it necessarily what it is, but it's pulling it from what has been coded. Because in the VA, we have the prescription data as well. It's showing me their prescription data, including most recent fill as well as drug interactions. It's showing me their laboratory data with the most recent labs and the frequency at which we told it we would like to have that monitored. Now on the right, you see hyperlinks that are identifying what potential clinical problem was identified, and there are potentially a number of them. But in this case, it's telling me that this is the clinical issue that needs to be addressed. And it gives me, by clicking that hyperlink, it then takes me to a place where I can say, yes, thank you for showing me that. I've addressed it clinically. Now, please remove this patient from my list, or perhaps even set a future date. Remind me if something hasn't changed in 3 months, perhaps. So this is how it allows us to operationalize the data that we're handed. This is from a study that was published out of Jeff Barnes' group in Michigan, where they looked at the number of VH of the Veterans Health sites with moderate to high DOAC dashboard usage adoption over time. And it was actually pretty dramatic. Keep in mind, this was a grassroots effort that spread initially by word of mouth. So the tool was developed in a single region in mid-2016, validated and tested and tweaked and worked on over some time, and then shared by word of mouth over the next year and a half or so. By January 2018, the tool was made nationally available, and you can see that just a natural uptake of this. By 2020, about 95% of VA sites were moderate to high users of the tool, with an average of 7.5 unique users per site. And again, not a mandated tool. It's just good evidence that when you create something that solves a problem, like Field of Dreams, if you build it, they will come. And so there was significant uptake over a relatively short period of time, and is now really the gold standard of care in VA. So the benefits of this tool have been published on. The very first study was Valencia et al. At a site in Florida, where they had a good clinic-based model, probably similar to what Katelyn presented, where they saw patients on some fixed schedule. They went through and reviewed the patients and they evaluated them. And then they introduced the DOAC PMT, and they compared side by side, looking at clinic efficiency. What they found was that significant interventions made per encounter nearly tripled with use of the PMT compared to standard of care. And it took about a quarter of the time to get to interventions. So 75% reduction in the mean time to intervention in the PMT versus the standard of care group. We also looked at a study, we actually looked at 20 VA sites that were high users of the tool versus 20 non-use sites. And you saw there were a number of different potential clinical issues. We looked only at one, really, at dosing. So if you strip away the DOAC tool and you simply say, now let's look at their population and look at inappropriate or potentially inappropriate dosing, do the populations look different? And indeed, the DOAC PMT was associated with a 4.3% absolute risk reduction in questionable dosing rates. And when you look specifically at the AFib subgroup, where if you really think about it, there's more potential to get the dosing wrong, the rates of questionable dosing was nearly twice as high in the standard of care group. 5.3% for the PMT group, 10.4 for the standard of care group, and it met statistical significance. So where does this model fit? Certainly PMT can't do everything, but it can be a very efficient part of kind of the maintenance phase of therapy. This is a model that I have promoted that incorporates PMT. And you'll see that PMT is kind of wrapped by good upfront processes and good back-end processes. So I firmly believe that we are a specialty service. We are not a asking permission for drug or a formulary sheriffing type service. We are a specialty service like any other. So we receive a consult for our services, and that consult undergoes expert review, pushing back on therapies that are wrong, or guiding where there needs to be some guidance, ensuring an appropriate dosing agent dose, that kind of thing. We also at that point provide patient caregiver education, and if indicated, provider education if something needs to be addressed. Because the PMT can't do everything, and especially early on, we do a 2 to 4 week call to assess for early adherence to therapy. The PMT can't really pick up early adherence rates because it's based on fills of the prescription. To also evaluate for early complications. If you start an anticoagulant on someone, if a bleed's going to occur, it's often when you first challenge them with an anticoagulant. And then, of course, to readdress any educational needs for those new to therapy where they're most likely to get things wrong. The PMT is then used to oversee patients on the therapy. And if they go 2 years without ever being handed to us to look at anything, it means they didn't need us to, essentially. But if anything flags, if dosing's wrong, or if the meds simply need to be renewed and evaluated, then it will address, it will flag. Now, it's also important to do periodic risk benefit assessments. We don't do this on a fixed schedule because generally the periodic risk assessments will present themselves. The need to do them will present themselves. Examples being things like evaluating duration of care 3 months after an acute VTE. That should happen. At the time of a bleeding or thrombotic complication, or perhaps if patients are converting to end of life decisions, palliative care, we need to stop and think about what we're doing. And also just at the time of med renewal, if we're not renewing it, if the provider's not renewing it, we are evaluating risk benefit, of course, at that point. So now pushing beyond individual patient management with population health, you can also use population health for quality assurance. And quality assurance, of course, is an important part of AC stewardship, and population health tools can allow for evaluation of care quality at multiple levels. Are we doing right for this patient? Are we doing right for this team? Is this provider, providing good quality care? What about the individual practice site or the whole health system? We can look as far as regional and national at quality using big data. So Jen Vong and colleagues presented at the AC Forum meeting on the kind of some additional quality tools that have been built and added to the DOAC PMT within VA. On the left, I apologize, these are small and some of them are a bit blurry, but you can look at your overall population and how you're doing with questionable dosing rates. Not only are they dosed correctly or not, but what are the individual dosing issues? So for example, is it that we're bad about underdosing rivaroxaban for atrial fibrillation? We're bad about in atrial fibrillation using a 2.5 milligram BID dose when they don't meet 2 out of 3 criteria, or even things like, are we considering dose reduction at the end of the 6-month course for VTE? So specific dosing issues, and if you see kind of to the middle and to the right of that, you can look at your local dosing issues per 1,000 DOAC patients, but you can then compare that to how does it look compared to the VISN, which consider that term in the VA to be regional, and nationally, national averages. In the bottom right, we have DOAC adherence rates, and I put that in quotations because what it really means is the patient is more than 35 days late for a fill of prescription. And you can see that you can look at your local adherence rates and compare that to VISN and national averages as well. Also, monitoring and tracking for events are important, and there are tools that have now been built that allow us to capture event rates either by ICD-9 based bleeding or thromboembolic events or reported events placed as what's called a health factor in the medical record, telling the medical record this happened. We can pull that report, we can accumulate those data, and we can actually validate those data on the bottom left here by saying, yes, this is a real event. In fact, it was a major event, or it was a minor bleeding event. Or no, this was not, dismiss this event. It was not the original kind of event. And that, of course, allows us to get to event rate numbers for the purpose of reporting and evaluating trends. Bottom right, we also have a report that allows us to identify when reversal agents have been used. So we can go into those cases, review those cases, determine if in fact they have that the use is appropriate, or if there's a problem we need to address. So what about using population health then to address specific AC stewardship efforts? So maybe you have a specific target. Well, Katelyn mentioned antiplatelet therapy, and this has actually been done. There was a region in VA that has been piloting a DOAC and concomitant antiplatelet therapy flag to be added to the PMT potentially. And this is some evidence from what they did over the course of 2022, most of 2022. You see on the left in the grayed out boxes, you see kind of this natural, most sites kind of trended down in antiplatelet use. So there's been some attention to it, but in red, you see the site that used the flag, and they actually had a 2.1% decrease, an additional, 2.1% decrease in concomitant antiplatelet co-prescription compared to the control group. On the right, the individual sites that make up that VISN or that region, you can see that they started at different places with their concomitant antiplatelet use, and some sites had more dramatic change in concomitant antiplatelet use as a result of the tool than others. The same concept can be applied to NSAIDs. It can be applied to consideration of adding PPI if patients are going to continue antiplatelet and so on. And then what about when we think about stewardship, we're often thinking about good management of patients who have been referred to us on an anticoagulant, but I think that really putting your arms around patients, not only on those who are on anticoagulants, but those who perhaps are not and should be, would be part of a good anticoagulation stewardship approach. So here in Salt Lake City, we presented this, at the American College of Cardiology meeting in March. We used data, we used population health to identify patients who looked like they had atrial fibrillation. They had a non-sex CHADS VAS score of at least 2, which would indicate them pretty strongly for anticoagulation therapy, and they were not prescribed anticoagulation therapy. And we did this as a pilot project to really to validate and refine data to inform the development of a population health tool to allow us this approach to be taken broadly, to define reasons and rationale for oral anticoagulation non-use. So we see these published papers that come out and say, OAC non-use is X percent, but it would be nice if we could actually chart review and see what's real. Those large data pools are often inaccurate. And to identify potential opportunities for intervention, to examine and address health disparities as it relates to OAC. We had a particular health disparities approach to this project. And this was done to inform a broader VA untreated AFib project. What we found was the data is not always accurate. 27 patients that we reviewed, they were already on an oral anticoagulant. They just weren't getting it from the VA, and the diagnosis was inaccurate in 36 of the patients. 29% of the patients truly had an unfavorable risk benefit, or the therapy was inconsistent with goals of care, such as end of life. Now, the opportunity surprised us. We expected to have significant opportunity to just put patients on therapy. What we found was our site did a really good job of considering and asking the question about oral anticoagulation therapy and using it where appropriate. There were 31 patients who would kind of repeatedly decline therapy, and there was an opportunity to get at those patients with repeated education and attempts. There were the largest percentage of the patients were actually those that were atrial fibrillation was accurate, which has VAS score, justified therapy. But their AFib was actually transient or episodic or of low burden and not deemed to rise to the level of anticoagulation therapy by their specialist. And then the one surprising opportunity that we found was when oral anticoagulation therapy was not used. That was typically where the conversation stopped. And so we're having a push really to identify consideration of left atrial appendage occlusion or other non-pharmacologic approaches. Now, that was to be the end of my presentation until last week, hot off the presses. This publication hit, which was so with the topic, I felt like we had to include it. The Association of Direct Oral Anticoagulation Management Strategies with Clinical Outcomes for Adults with AFib, right along with the topic of what we're discussing. So this study, the objective was to compare the outcomes associated with 3 DOAC care models: usual care, which was really provider prescribing the drug and managing it; usual care plus the use of a type of population management tool. This is not the VA, this was a different health system. And then pharmacists managed anticoagulation management service, probably similar to what you saw from Katelyn, although probably less. It seemed to be in looking at their follow-up, it was probably not as close of monitoring. This is a retrospective cohort study of nearly 45,000 patients initiated on DOACs or warfarin between mid-2016 and the end of 2019 in 3 Kaiser Permanente regions over a median follow-up of 2 years. DOAC care models versus warfarin. So they really looked at DOAC care models versus warfarin as a common comparator within each group, as well as DOAC care models compared across groups, with the outcomes of first occurrence of a composite outcome of thromboembolic stroke, ICH, major bleeding, death, discontinuation from Kaiser Permanente membership, or the end of 2020. Their summary was as follows. DOACs were associated with favorable outcomes compared with warfarin, but we did not establish superiority of any system level DOAC therapy management service over usual care, which is concerning. That is a little bit counterintuitive. We would think that managing more closely might give better outcomes, but we need to put this study in perspective. It was a single system, retrospective, ICD-based review limited to an HFID population. And interesting to Kaiser Permanente, dabigatran represented 84 to 93% of all DOACs used, which is not at all representative of other anticoagulation populations largely. And really less, if you think about dabigatran dosing versus some of the other dosing, is less chances to get the dosing wrong, especially if you don't believe in the 75 milligram dose, which was never clinically proven. Kaiser Permanente also has really a long history of strong clinical pharmacy practices and anticoagulation practices in general. So it could be that we were looking at good practice versus good practice done differently. And details were not given about the anticoagulation management service or details were given about the anticoagulation management and PMT models, but not about what may have been in place to guide usual care. So did they have decision support in place? Did they have strong formulary management processes? We don't know. This was an interesting inclusion in that paper. This forest plot, as I mentioned, they could first compared DOAC to warfarin within individual sites. So this is an association of direct oral anticoagulants versus warfarin with major clinical outcomes by DOAC management style. What kind of jumps out at me is if you look at the top row, the net clinical benefit, both the urgent care plus PMT group and the anticoagulation management service, the confidence intervals actually exclude 0, which is not true for the usual care model. Also, you notice what the circles, that when PMT is added, the confidence interval lines are way shorter, and that's because look at the massive number of patients they were able to manage using only 3 pharmacists. Almost 22,000 patients were followed in that model of care. And so really what this teaches us is that this is certainly a usual care and anticoagulation management services are as good as usual care, and the addition of population management allows you to do good care quite efficiently. So summarizing, technology and the move to electronic health records have really unlocked massive opportunities for the use, study, and operationalization of health data. For many years, VHA has harnessed the power of population data to improve the quality of care across disease states and has led the way in population health as part of anticoag stewardship efforts. Now with spread beyond VHA, with Mackey in Michigan kind of mirroring the VHA's approach in EPIC and rolling that out across some University of Michigan hospitals. And the AC Forum really actively promoting population health as a component of anticoagulation stewardship with 2 ongoing projects surrounding the use of digital tools. And really that recent publication that I just presented highlights the stance, as I mentioned at the start, that we should work smarter, not harder. And we'll go to panel discussion at this time. Thank you.
Wow, what a robust conversation. And thank you both Katelyn and Arthur for your comments. And yeah, obviously 2 very different styles of management. Katelyn's being more of a system where you need to pull the information, whereas Arthur's being a system that pulls the information to you. So we are going to jump right into a panel discussion. And let's try to do as rapid fire as we can to try to get as many questions answered as possible. Katelyn's been hitting up the question and answer like the amazing person she is in answering so many of your questions. So first, I'd like to jump over to Dr. Geller and ask if you have any comments on this discussion from a CDC perspective, and what the CDC likes to see regarding anticoagulation management services, where we'd like to be in the future. And we just really appreciate the work that's been done by the CDC in this space.
Yeah, thank you. So briefly, about 10 years ago, the federal government, Department of Health and Human Services came out with the National Action Plan for Adverse Drug Event Prevention, trying to look at how to prevent the most common causes of medication-related harms. And certainly anticoagulation is one of the most common causes of emergency room visits and hospitalizations, particularly among older adults. And so one of the things that we would like to see, talking about the federal family, not just CDC, is advancing of the anticoagulation stewardship model, multidisciplinary, coordinated, systematic approaches to care, about which you've heard just now in many different fashions. And the analogy has been made to the successful approach that we know works in improving antibiotic use, and sort of expanding that, and sort of really just supporting the best practices and gathering data and implementing it so that the right patient gets the right medication at the right dose. Thank you.
Jean, I'll let you get the next question if you have one. Otherwise, I can tee it up.
Yeah, no, I think Arthur's presentation and Katelyn's presentations were very synergistic with regard to different styles and different approaches, and potentially using EHR and leveraging it in different ways. One thing I wanted to mention, and I think Arthur, I would love your comments and Katelyn's comments about that last publication that came out. And because I think that we need to take that publication a bit with a grain of salt, and not be ready to throw out specific stewardship programs or DOAC management clinics based on that. As you pointed out, Arthur, 21,000 patients in the usual care plus PMT versus 2,000 in the other two arms, and the use of dabigatran. And so I think without more granular information, I think it's a very interesting study, but I'm not sure that what was done in those situations really apply to the models that either Katelyn discussed or that you discussed, Arthur. So I don't know if either of you want to comment on how you view that and how it might affect moving forward in this sphere. And also, Dr. Geller, would love your comments as well.
Yeah, just real quickly, I'll say that, first of all, let me congratulate the authors on the publication, because one of the things that I was concerned about from the very beginning of DOACs kind of hitting the market and us trying to oversee them was, how can you justify it, and how do we know that what we're doing is justified? Seeing patients on a fixed schedule, checking creatinine once a year versus twice a year versus every 3 months. There's been nothing that says that if we do that, we make patients live longer. And so the fact that they undertook a study to try to finally define, what should we be doing, I want to congratulate them on that effort. But I do think you bring up some valid points that that unless we know exactly what those models are and exactly what they were doing, that we don't want to throw the baby out with the bathwater. And what I'm a little concerned about is C-suites, when we're trying to beg and say we need to have we need to have some support to develop these programs or to oversee these high-risk patients, to have a tool where they can say, well, this study says it doesn't matter. I'm a little concerned about it being misused by C-suites, where folks like us can absolutely look at it and go, well, yeah, I get that, but C-suites might say, so it doesn't work, I'm not going to pay for it. So that's kind of my concern.
Yeah, Katelyn, I don't know if you have comments.
Yeah, I don't have much to add other than I think it's really important to think about making sure we have the right tools. I think it's pretty clear that DOAC patients need something different, right? There's so many admissions and ED visits for bleeding related events, which we know the drugs are going to cause bleeding, but what can we do that's going to make a clinical difference? And I think whether that's time, whether it's larger studies, but I think we absolutely need the tools to be able to drive us to making the right interventions, so that we're not looking for needles in haystacks, but we're really hitting the patient where we're really making the difference where we need to. So some combination, I thought that usual care plus the patient monitoring tool was really interesting. But again, I think we just don't know, besides the fact that we know something needs to happen.
Yeah, I would just like to add before I ask Dr. Geller for his comments is that I will say that here at Brigham and Women's Hospital, the AMS is a very value added service, right? We have pharmacists working at the top of their license. They're switching anticoagulants if the type is inappropriate or the patient can't get it because of insurance blocks. We also have them following creatinines and adjusting the dose. And that takes a huge burden of work off physicians and other providers. So I think we have to sort of figure out how that fits into the workflow and how that saves time and effort across the board. Dr. Geller, any comments about this intriguing study, which I agree needed to be done? But the details or the devil's in the details of actually the differences between their strategies and the ones we're talking about today.
Yes, thank you. I don't have anything substantive to add. I will just say, our study on anticoagulant-related bleeding, the DOACs, dabigatran was very small proportion prescribed, and the bleeding that is reflected of that. So our study that we did really wasn't a dabigatran study. That was the only thing.
Yeah, I might just add one final thought if I could, Jean. One of the things that it does make me wonder is, would we be better served by going after some of the other initiatives that I described, like spending our time and efforts on antiplatelet therapy, on concomitant NSAIDs, on PPIs, on those types of efforts, as opposed to laboratory monitoring, dosing, screening for drug interactions. It makes me kind of wonder if we think about juice for the squeeze. Perhaps juice for the squeeze is better spent where we're more likely to impact outcomes, because I refuse to believe that if you take a site from 40% concomitant aspirin use to 10% concomitant aspirin use, that you're not going to have an impact on bleeding complications.
Yeah, and to your point, and I think Dr. Geller mentioned this, dabigatran is a great drug, but for very carefully selected patients, right? Good renal function, reasonable age, low risk of bleeding. So that some of the events, to your point, Arthur, are seen in a different population than treated with dabigatran. So I think we need to keep all of those factors in mind when we review that intriguing paper. I'd like to thank everyone for participating. There are a few housekeeping slides that we just want to share with our audience. We want to thank the audience for joining us today. And I'm going to just give you an update of what's to come in the future. So please register and sign up for the AC Forum webinar that's going to be held on Wednesday, August 30th, where we will discuss the newly released ASH thrombophilia testing guidelines with Stefan Moll presenting. Stefan was part of the ASH panel that wrote and developed the guidelines. Myself and Dr. Subash Palkimas will be panelists, and Jury May from University of Alabama will be moderating. And I think I'm not in presenter mode, but here we go. You can look at our webinar archives on YouTube at Anticoag Forum. Follow us on all forms of social media. There is a lot of information out there, including on the AC Forum website. And last but not least, and very important, and I know our staff here at Brigham and Women's Hospital have found the Anticoagulation Forum boot camp to be of significant importance. Here's information for the online virtual boot camp to take place in October. You can see the URL at the bottom. So Google it and sign up. And I would encourage all anti-coag service providers to participate in the AC Forum Bootcamp. And with that, we want to thank you for attending our webinar today. Take care.